To educate us about ostomies, I have the distinct pleasure of introducing Dr. Jason Harper, who is the director of the IBD program at Harborview Medical Center at the University of Washington, and just a wonderful guy to know.
All right, guys, last talk of the day. It's been wonderful so far. I really appreciated getting this topic at first. There's for two reasons. One is that the presentation I'm going to give you is actually a very aspirational presentation. This is the provider I wish I would be in terms of some of the things that I'll tell you. Because in reality, when one of my patients has a problem with their stoma, my first few questions are, oh my gosh, have you spoken to your ostomy nurse? Have you spoken to your dermatologist? Have you spoken to your surgeon? Why are you asking me about this? I'm going to encourage a different approach. On a personal level, I was kind of pleased to get this topic because I can speak a little bit about some of the personal aspects of what ostomates go through, because my dad has been an ostomate since he was in his 20s. So I have known about stomas for as long as I can remember, at least some of the things, about having a sense of humor about having a stoma, carrying extra supplies on long car trips. Swimming is absolutely okay with a stoma. So there's a personal aspect to this that was fun to review. I have no disclosures. I'm working on it. And really the way this is going to be structured is a talk about living with a stoma. A talk about stomas could occupy an entire conference. So I decided to focus in on just at least personally some of the triage and management decisions, some of the quick in-office things that I often get questions about from folks with a stoma, and how I try to approach these. A little bit of definitions I'm going to gloss over the next few slides. Keep in mind when we're talking about a stoma, we're talking about some kind of an external orifice that's been created to remove waste products, and they come in all different varieties based on anatomic location, up to and including urostomies to drain urine externally. That's obviously not something that we are going to be dealing with. Ostomies have different issues that arise depending upon the place in the GI tract that is being diverted. So most ostomies, when we think about that, we're thinking about an ileostomy. But colostomies offer different advantages in some cases for folks who can get away with having one. And not commonly, but you can also see more proximal ostomies that can be quite difficult to manage from a fluid and electrolyte standpoint, the more bowel is being basically bypassed. I'm going to skip over this. There's innumerable numbers of appliance and bag systems, everything from sort of one-use bags and appliances all in one that can be thrown away as soon as they're used, to two-step systems. I'm not going to talk about that too much. Really, the three scenarios that I wanted to talk about were the basic question of something looks weird about the skin around my stoma. My stoma is doing something weird. It's putting out too much, too little, not enough. And the third being my stoma itself looks funny. So what do we do with some of those scenarios? So in terms of peristomal rashes, these are obviously incredibly common. In fact, I would argue that pretty much everybody who has a stoma long enough will at some point or another run into an issue with the skin around their stoma. The risk factors for this tend to be issues that would arise in terms of seating the appliance well. So folks that have variant abdominal anatomy might be more prone to these issues. And I'm just going to say at the outset, because this is actually a quality metric that has been shown to be associated with better quality care for ostomates, and if absent, worse quality care, is ready access to a wound and ostomy care nurse. For any of you in the audience who might have a background in this, thank you so much. Making friends with a good ostomy care nurse is your best thing to do, and it's your patient's best thing to do. So a lot of what I'm going to say, for those of you who have a background in this, is probably going to be redundant. So we're just going to go through some pictures. We all have our wheelhouse, right? Like my patients often ask me, like, GI, ugh, like why did you choose that? But you got to know your strengths and your weaknesses. And for me, like rashes and eyeballs, those are two arenas I don't want to touch with a 10-foot pole. The advent of a smartphone is wonderful. So when I said aspirational, reality is if your patient is coming to you with a problem of the skin surrounding their stoma, you got to look at it. But smartphones are great for this because they will often have taken pictures of this, and they can show you the evolution of the rash over time, which is something that you're not privy to. So, okay, first picture here. I'm not going to solicit random guesses from the audience because in interest of time, but I'll just tell you what this is. This is meant to be a representative picture of arguably the most common peristomal rash that you're going to be dealing with, which is basically an irritant dermatitis. So ostomy effluent is pretty caustic to skin, especially ileostomy effluent. This is bile. This is mildly acidic, and it stands to reason that if this is allowed to stay in close contact in a moist covered area for extended periods of time, your skin is not going to be happy. So what you're looking for on exam is skin that is very moist, weepy, erythematous. There is usually pain associated with this. It's usually not pain out of proportion to the appearance of the rash, however. And a sort of a tip-off or a clue would be that you're looking for the rash to be delineated or defined by an area that might not be covered well by this person's appliance. Anything that we talk about, this condition, such as it is, often tends to coexist with a lot of the other peristomal rashes that we're talking about. So you're never wrong applying some very basic principles here that you would be applying also in cohort, hopefully with this individual's ostomy care nurse and other members of their stoma care team. The big sort of low-hanging fruit are making sure that their appliance is fitted adequately and that there's not a significant gap between their stoma and the appliance. We'll talk a little bit more about this. For individuals who have a retracted stoma, they will usually need special appliances to make sure that they're getting a snug fit and that stuff is not undermining underneath their adhesive. Make sure they do keep the area clean, but that they're not using really harsh detergents or soaps to clean the area. I guess the big takeaway I would also say is that it's, again, and this is why it's important to work with a wound and ostomy care nurse who is going to be familiar with some of these, is using, whether it be drying powders, whether it be barrier sprays, barrier ointments. Ideally, you want to make sure that your patients are using things that are actually designed for stoma care and not stuff that they're just pulling off the shelf, like baby powder to try to dry, or cornstarch to try to dry up the skin around their stoma. For severe cases, you can also use, for a period of time, you can use topical corticosteroids if there's quite a lot of inflammation of the skin, but you obviously want to minimize those as much as you can. So this picture here shows basically what essentially amounts to an epidermal abrasion that is actually nowhere near the stoma itself. So any guesses as to what might be going on here? I said I wasn't going to do that, but any guesses? What's that? Yes, this is mechanical trauma. Very nice. So what you're looking for here, the tip-offs here, this is basically what this is implying is that this is a surface level. This is an epidermal loss of integrity, which is often due, in this case, to various factors, but probably somebody who's being a little over-aggressive with taking their appliance off. Risk factors for things like this are going to be your risk factors for skin fragility in the first place. So folks who are older, folks who've been on a lot of corticosteroids, malnourished, their skin's more fragile. They could literally just be tearing the skin with frequent appliance changes. The appliance might not be fit correctly. They may be scrubbing the skin too much or cleaning it too much. So the basic principles of treating this, again, we kind of don't want to belabor the point. All right. Here's another one. Any guesses? Redness. We got one vote for redness. Okay. So this is, I guess, meant to be a representative picture of candidiasis. So what are your tip-offs here? And again, this is, I'm beating a dead horse. A lot of these things are going to coexist with each other. They don't arise in a vacuum. But some of the tip-offs for candida is really intense erythema out of proportion to, not a cellulitis, not necessarily indurated, not necessarily painful to touch. Really intense, shiny erythema. Sometimes there's some small papules in the area, often very itchy, more so than painful. And again, in addition to everything else we want to do for basic stoma skin care, the addition of a topical antifungal, you're never necessarily wrong in suggesting that in a lot of these cases. Okay, what do we think here? Any thoughts here? Keep in mind, it's like kind of square shaped. It's taking up the entire, what guesses? Allergy, I heard allergy. I heard a lot of murmuring, and then I heard allergy. Yeah, this is an allergic contact dermatitis, where your tip-off is going to be basically the morphology of the rash conforming to whether it's the adhesive, whether it's something topical that they're putting on. This is exactly akin to what happens, in folks, present company included, who have like a nickel sensitivity, and you get that nice, it shows up exactly where you're putting the stuff on. Tends to, yes, be weepy. Maybe you get some blistering in the area, usually very itchy. So you can do a little detective work. Is it the adhesive? Is it some cream or some powder or something that they're using? Remove the offended agent, topical corticosteroids if it's pretty bad. And if you want to confirm for whatever reason, if you're curious, then you can do patch testing somewhere else on the body to confirm this. All right, how about this one? You guys are good, by the way, unless I'm just lifting all the same standard Google image pictures for these. Any guesses as to this one? You see little red bumps all around the stoma. Anything? Bueller? This is meant to be an example of peristomal folliculitis, right? Beard folliculitis. So patients of yours who might have a more hirsute abdomen, they need to get their appliance to stick to it, so they're going to have to shave if there's a lot of abdominal hair. And it's basically a folliculitis exactly that somebody might get from shaving their beard, little itchy bumps, pustules, surrounding the stoma in an area of where there's hair. Little tricks you can use to avoid this: electric shavers, more so than razor blades. Shave with the grain of the hair, not against the grain of the hair. And you can use topical antibiotics, bacitracin, things like that to help clear this up. I don't think you're going to see too much of this, so I don't really know why I included it. So I'm not going to harbor any guesses. If anybody knows what this is a picture of, kudos to you, because probably not going to see too much of this. But this is meant to represent a mucocutaneous separation. The reason I'm not going to belabor this too much is that this is really a complication early after stoma surgery. So it's likely not something that, unless you're working with somebody very fresh into their stoma, that you're going to see. And it's exactly what it suggests, which is that the skin and the stoma have separated from each other, the risk factors for this usually being anything that would impair wound healing in the first place. It's important to recognize and get these folks back to their surgeon and wound care team very quickly, because this has to be managed immediately, and it's usually going to be managed by meticulous wound care to the area to allow that to granulate in and heal. All right, this is an important one. This is kind of a can't miss one, because it's going to be managed so different. I mean, a lot of the basic principles, right, they overlap, but this is kind of a can't miss one. Anybody have any thoughts as to what this is showing? I heard some whisperings. This is pyoderma. This is peristomal pyoderma. And this is maybe, at least from a GI standpoint, the one we're going to have the most input and say into helping direct the management of. So pyoderma gangrenosum, it's a neutrophilic dermatosis. It is in many cases idiopathic, but it's also associated with a whole host of autoimmune and hematologic conditions, and IBD is one of that long list. So while any ostomate can theoretically get pyoderma, you are going to see it more commonly in folks who have a pre-existent history of inflammatory bowel disease. I would also point out that the presence of pyoderma is not in and of itself proof positive, if they do happen to have IBD, that their underlying IBD is luminally back. You can get this in isolation. So the person who has ulcerative colitis, you remove their colon, they do not have any small bowel disease, they can still get pyoderma. The classic variety of pyoderma, which is the one that you almost exclusively see in folks with IBD, and this is where actually the evolution can be helpful, because by the time they come to see you, they come to see you with the ulcer most typically. And there's a lot of things that can cause ulcers around a stoma. The story they will likely give you, though, is that this all started off as sort of a purplish, bluish nodule, maybe like a pustule, that just really quickly opened up into a rapidly spreading ulcer. Another clue is the so-called cat's claw ulcers, where it can initially start off looking like multiple, bizarre-looking linear ulcers that then coalesce into one big ulcer. The edges are usually rolled up, bluish-purple, and pyoderma is extremely painful. Those are your cues to the diagnosis. How do you manage this? Hopefully in concert with a dermatologist who is comfortable and familiar with managing pyoderma and managing folks with inflammatory bowel disease. They may or may not suggest a punch biopsy of this, not to confirm the diagnosis, because there's nothing pathognomonic about pyoderma, but to exclude superinfection, which can occur in these individuals. And the reason this is important to identify is because the treatment for this is immunosuppressive therapy. Ideally topical in most cases, or you can do local injection into the ulcers of Kenalog, and that'll clear them up often very quickly. But in more severe or refractory cases, you have to use systemic agents to keep this under control. And this can be pretty problematic in some situations. Resiting the stoma does not, by the way, fix this. I don't know why I'm putting that out, but I've heard it bandied about. Okay, we're gonna start flying, but it's the end of you gave me the end of the day, so captive audience, right? How about the stoma that's putting out what it shouldn't be putting out? And really, most of the time, what I think the clinically actionable thing we need to be concerned about is when folks are coming to us with a high output stoma, and how do we manage that? Because it is incredibly easy for these folks, especially with an ileostomy or particularly a more proximal ostomy, to dehydrate themselves very dangerously and very quickly if you're not careful. So what defines a high output stoma? Anywhere between more than 1 liter to 1.5 liters of stool per day with clinical signs and symptoms of hypovolemia. Keep in mind that physiologically, your small bowel presents about 1 liter of content to your colon for salvage of that extra kind of 800 milliliters of fluid and electrolytes. So 1 liter of output a day is what is already being presented to your colon on average. Working up a high output stoma is really, it's working up diarrhea broadly speaking, but there are just some specific and special situations you probably need to be a little bit more in tune to by virtue of the population that you're working with having an ostomy. So these would be things, especially in your IBD patients, to consider. Upstream obstruction can sometimes paradoxically manifest as a high output stoma. An interloop bowel fistula can manifest this way. Abs to colon, people can still get all the fun stuff that people with colons can get. So that includes C. diff enteritis. Knowing how much bowel they have left can also determine how aggressively you're going to manage a high output stoma and how long you're going to need to manage it for. And in considering your differential, considering the timing from original surgery, because a high output stoma immediately after surgery, there are some physiologic adaptive mechanisms that haven't kicked in yet when people have a brand new stoma that will likely kick in over time versus the person who's had a high output stoma from the get-go. So without getting into very specific etiologies, the basics of management, a lot of this is basically just counseling your patients. First and foremost, as it is for everybody, but especially for persons with stomas. This one I confirmed with my dad. Urine output is like your canary in the coal mine. When the stoma starts gushing, people just stop peeing, period. Like your intestines can work as a really good kidney for a period of time. What's coming out of you, if you go back to your physiology, the GI tract is not a kidney, however, in that it cannot concentrate or dilute what comes out of it relative to plasma. So the stuff that's flying out is isotonic to plasma, and this is the key. This is why these folks, you have to counsel them. If they get sick, they get a stomach bug, their stoma starts pouring out, they do not replace with hypotonic fluids. This is a big mistake. These are the folks that come into the ER with sodiums of 120. It needs to be, what they're replacing with needs to be kind of salty. Also keep in mind that even though the tonicity of small bowel contents is equal to that of plasma, the electrolyte concentration is not the same. There tends to be preferential wasting of potassium, magnesium, and bicarb in these individuals. Treating the hypomagnesemia that can go hand in hand with a high output stoma is really challenging because then you're kind of balancing the fact that magnesium supplements in and of themselves induce an osmotic diarrhea. So that can be, all of this can be very challenging to micromanage. Sort of belabored the point about oral rehydration. Also teach patients how to make this on their own with readily available ingredients that they have in their pantry. I would encourage everybody, if they haven't done so, to try what oral rehydration solution actually tastes like, or try some of these fluids that we recommend for replacement, because the key is, like, if you think it tastes good, they're not making it right. It needs to be more salty than you'd expect. When it comes beyond that, I mean, basically the principles, and some people really do depend on this long term, are to get aggressive with your antidiarrheals. So another just quick pearl when it comes to using antidiarrheals is one of the most common things I see when I get these referrals is an acute lack of Imodium deficiency is what they're really suffering from. Imodium, loperamide, undergoes enterohepatic circulation. So if you have somebody who has lost small bowel length, they will clear Imodium out of their system a lot faster. So even the max doses that you see on the package inserts do not hold for people with short gut, for people with stomas. They might need a lot of Imodium to start slowing things down, and yet that's still the best place to start. You got your low modal, a little bit more bang for your buck, but keep in mind the atropine in there can add up, especially in folks who would be more sensitive to anticholinergic side effects. Very rarely should we be using chronic opiates to control this, but in really extreme cases, sometimes we have to, keeping in mind the potential for abuse there. Anti-secretory agents can be helpful for short-term. This is one of those physiologic adaptive mechanisms that people are not often aware of when they're brand new to having a stoma, is that when you get a new stoma that involves removal of some of your ileum and certainly your colon, you secrete more stomach acid for a period of time. So putting these folks on a PPI or an H2 blocker can help in the short term. Octreotide's not something we're going to reach for very often due to cost concerns. And then thickening agents can be sometimes helpful too, but of course be careful. You don't want them to over thicken what's coming out. Let's skip over this one because I've already run over. Because of this, because you don't want to switch them off to the other direction where they're having trouble with not enough coming out of their stoma. More of an issue for folks with a colostomy who are just as potentially prone to getting constipation as the rest of us, and which would be managed in the standard fashion. If you have a person with an ileostomy or more proximal ostomy who's not putting anything out for a period of time, you got to think obstruction first. Skip over this one. Stomal bleeding, I guess the only point I would keep in mind is just always keep an eye out for kind of punctate bleeding from the stoma surface itself, especially if they have a prolapsed stoma or there's any other trauma that's occurring to their stoma. Okay, then we're going to end with my stoma looks weird, and what do I do about that? So what do we have here? We have a stomal prolapse. We see a double barrel here. This is actually a double barrel ileostomy, and it's prolapsed. So this is not uncommon. This is more common with folks that have a colostomy or that have a loop ileostomy as opposed to an end ileostomy. The risk factors you have up there. For the most part, when this is a chronic occurrence, this is usually not, I mean, it's more of an annoyance per se when this is happening chronically. Always, of course, keep your eye out for signs of bowel compromise if this is happening very acutely. One little, if I had more image size, a fun little trick that you can sometimes see when you have an acute stomal prolapse, that there is a lot of edema and it's not reducible, is you can sprinkle a little table sugar on it. The whole thing will just retract back in. It's sort of the salt on a slug principle. And for colostomies, especially continent colostomies, where there's basically semi-predictable frequency of evacuation, you can also get stomal plugs for a continent colostomy. Can't obviously do that with an ileostomy because output is constant throughout the day. About this one, what's happened to this individual? Their stoma has retracted, it's hidden, popped in. So you could see this, for instance, especially in somebody who is very cachectic and malnourished heading into their surgery. All of a sudden their inflammation's gone. They might gain weight very rapidly, and that original stoma is now popped back in. We care about this in so much as particularly this causes a lot of issues with pouching when you have a retracted stoma. So these are folks, again, working with an ostomy nurse to find the right appliance for one of these individuals. It's the key to management. And then a very common issue that we run into is this one, which I didn't even give you a chance to guess because it's right there. It's a peristomal hernia. These are quite common. Risk factors for this, again, sort of similar to some of the other things that we've discussed. Management of this is going to be driven by how big it is, how uncomfortable it is, and obvious cosmetic concerns that some people would have if they have a very large protuberant peristomal hernia. I'll leave you to kind of read the slide. I think it's sort of self-explanatory how these are typically managed. You can try to conservatively manage smaller ones with hernia belts. Very large ones, to the extent that the individual in question had there, is typically going to require surgical correction if it's bothering them quite a bit, as I imagine it would be. Peristomal hernias, the good news is it's of course not unheard of, but it's unusual for these to actually present with things like clinical obstruction or strangulation of bowel in that hernia. I think that's it, so thank you.